It is just now 7 o'clock on the East Coast. It is June 3rd. It's a Thursday. As always, we like everyone to give everyone a chance to come on in and get settled. So we always start about 2 minutes after the hour. So if you're just joining us or you're just logging in, please feel free to say hello. Let us know where you're viewing from. Always give a shout out in the comment threads. Also feel free to, Fran just unloaded a fury of comments as an example. So let us know you're out there. Feel free to grab a seat. They're all comfy chairs, and we'll get started momentarily. Hello, Simone and Mart. Where's Mart? Oh, I was in Maryland, USA. I was like, Martine, interesting. Not familiar with that state. Welcome, Simone. Thank you for joining us. Hi, Dottie. Hope you're well. Get started in just about a minute. There's Tanya in Phoenix. Hi, Tanya. We have a really exceptional panel for you this evening. No disrespect to our previous 40 panels, but we're very excited to have, hi, Elizabeth from Texas, to have Dr. Goodman, Dr. Nolans, and Dr. Davis on. Incidentally, I did play a doctor on CSI Miami in 2003, so I can fit into this cohort, sort of, kind of, but not really. Welcome from Canada, Ontario. Thank you so much for joining. If you're just joining us, please say hello. Let us know where you're from. Feel free to leave comments in the comment thread. Of note, we'll probably be talking for about 30 or 45 minutes, and then we'll get to your questions. But if we can incorporate any of your comments into the conversation, we'll always try to do so. Good try, Ethan. I know. I'm sorry. It was a bad joke. I got Wayne sort of smirked, and that was the end of it. So with that, we are just 2 minutes after. So please, again, feel free to keep saying hello. Let us know you're out there, and we'll give this a start. So welcome to OCD Town Hall. This is Biological Treatments for OCD. My name is Ethan. I'm the National Advocate for the International OCD Foundation, which simply means I have OCD, and I won't stop talking about it, or at least until everyone can access effective treatment. So just some quick housekeeping. This town hall is intended to serve as educational content. It is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. The International OCD Foundation is not a crisis hotline. It should not be used if you're in distress or feel unsafe. If you're in a crisis or ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the suicide prevention hotline, which is just below at 800-273-8255. As always, we want to be respectful and kind of others. We try to create as safe a space as possible. Hey, Nikki Bradley in Dublin, and hi, Valerie Andrews. Create as safe a space as possible. Always keep in mind that we are on the internet on a variety of platforms that this recording will live on long after us. And so keep that in mind when you're asking questions. But again, we always want to be very respectful and kind, and hopefully have an honest and open conversation as possible in an effort to support everyone. Hi, Katie. How are you? So with that, let me go ahead and start making introductions. So first we have Dr. Rachel Davis. Rachel's Associate Professor of Psychiatry, Vice Chair for Clinical Affairs, Medical Director of Student Resident Mental Health, and Medical Director of the OCD Program at the University of Colorado, Anschutz Medical Campus. She is Service Director for the Department of Psychiatry, Psychiatric Neuromodulation, and Advanced Therapeutic Service, and she specializes in deep brain stimulation, or DBS, for refractory severe OCD. Dr. Davis completed her undergraduate degree, medical school, and psychiatric residency at the University of Colorado, and has been on faculty at the University of Colorado, Anschutz, for the past 11 years. She is currently a principal investigator on an NIH brain initiative studying the ethics of DBS, which is deep brain stimulation in schizophrenia. So thank you so much, Dr. Davis, for being here. You're on mute, sorry.
Thanks for having me.
Did I pronounce that right? Anschutz?
Anschutz, yeah.
Anschutz. Okay, all right, perfect. Next, we have Dr. Nolan Williams. Dr. Williams is an assistant professor within the Department of Psychiatry and Behavioral Sciences and the director of the Stanford Brain Stimulation Lab. Dr. Williams has a broad background in clinical neuroscience and is triple board certified in general neurology, general psychiatry, as well as behavioral neurology and neuropsychiatry. In addition, he has specific training and clinical expertise in the development of brain stimulation methodologies under Dr. Mark George. Themes of his work include development and mechanistic understanding of rapid-acting antidepressants and identifying objective biomarkers that predict neuromodulation responses in treatment-resistant neuropsychiatric conditions. He has published papers in high-impact peer-reviewed journals, including Brain, American Journal of Psychiatry, and the Proceedings of the National Academy of Science. Results from his studies have gained widespread attention in journals such as Science and New England Journal of Medicine, Journal Watch, as well as in popular press, and have been featured in various news sources, including Time, Smithsonian, and Newsweek. Dr. Williams received the two NARSAD Young Investigator Awards in 2016 and 2018, along with the 2019 Gerald R. Klerman Award. Dr. Williams received the National Institute of Mental Health Behavioral Research Award for Innovative New Scientist in 2020. Thank you so much, Dr. Williams, for joining us.
Thanks for having me. Great to be here.
Absolutely. And last but certainly not least, we have Dr. Wayne Goodman. Dr. Goodman is the Irene L. Wood Professor and Chair of the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine, specializes in obsessive compulsive disorder, OCD, and DBS, deep brain stimulation, for intraceable psychiatric illnesses. Intractable. Intraceable is a whole different other thing. He's the principal developer of the Yale Brown Obsessive Compulsive Scale, or the Y-Box, which is the gold standard for assessing OCD, and co-founder of the International OCD Foundation, the major advocacy group for patients with OCD. He did indeed found what was then the OCD Foundation. When it was it 1987, Wayne?
1986.
Okay, 1986. So we would all not be here if it weren't for Wayne and Patty Jenkins and so many other amazing folks back then. Prior to joining Baylor, he held senior administrative positions at Mount Sinai Hospital in New York, NIMH, and the University of Florida. He graduated from Columbia University with a degree in electrical engineering, received his medical degree from Boston University School of Medicine, and completed his internship, residency, and research fellowship at Yale School of Medicine, while he remained on faculty for 7 years. He is currently a principal investigator on grants for NIHS's Brain Initiative, including one on developing adaptive DBS for OCD. So thank you all so much for being here. I think we have a well-credentialed crew. And as always, if you're just joining us, please feel free to leave a comment in the comment thread. We will definitely get to questions momentarily. But in the meantime, I will start things off. So with that, I think perhaps we should start. Oh, and let me preface by saying, usually on these town halls and Just Ethan live streams, we try to veer away from medication questions, mostly because we don't have a doctor or psychiatrist on the panel. Tonight we have 3, and so you can ask 3 times the medicine questions that you'd normally ask. No, but in all sincerity, feel free to ask questions as we go along the lines of medication, and we'll be happy to answer to the best of our ability. And with that, let's start with medications for the treatment of OCD. I'll start with Dr. Davis. Dr. Davis, where do you think we are in general with medications for OCD efficacy? I know that there's some fairly new research coming out and studies, but we have SSRIs, the last one in 1997. And since then, there's sort of been this long gap, some off-label things. Give us your overall assumption of sort of where we are with meds, pharmacology.
Sure. So, we have a number of medications. The primary medications we use in OCD are medications that act on serotonin, and they work fairly well for, a significant number of people. But often medication alone isn't enough. There's still probably 40 to 60% of people, even with, adequate medication treatment, who have residual symptoms. And that's where therapy, specifically ERP, comes in and is really important for most people with OCD. The medications that act on serotonin, the first one that we had available was clomipramine. That's an older antidepressant. It's in the class called tricyclics. Since then, we've had a number of other medications, mostly SSRIs or selective serotonin reuptake inhibitors. Those are things like, I'll use generic names, fluoxetine, paroxetine, sertraline, fluvoxamine, all those medications we use for OCD as well. One of the key things about medication for OCD is we often need to use high doses to achieve maximal effect. And it can take longer for people to respond than, say, for depression or generalized anxiety disorder. We really say you need a good 12-week trial at maximum dose before we say something doesn't work.
Thank you, Rachel. Curious, Dr. Goodman, why is that? Why does it take the high end of the dose range?
It's a good question, but I totally agree with Dr. Davis's synopsis of where we are with medications. I mean, early on, so I go back away. As you pointed out, and I was starting when I was at Yale and developing my interest in OCD. I was involved with some of the early trials with SSRIs. Actually, did a lot with fluvoxamine and also clomipramine. And when we first started, we were thinking it was going to be like depression, and we were doing trials that were 6 to 8 weeks and lower doses. And we just found with experience that it takes longer and sometimes higher dose. It doesn't mean, though, what I would tell patients or when I'm teaching residents, doesn't mean you have to go right away to a higher dose. It's really important early on to help make sure the patient is tolerating the medication. And if you go up too quickly on the dose, you're going to encounter side effects, and then you may have an aborted trial. So although I totally agree that oftentimes we go to higher doses, it should be gradual and titrated, adjusted depending upon side effects, and not going any higher than necessary. But I think your question is biologically why? I don't know the answer. Why it takes longer, and we don't even know why. It's just the antidepressants that work on serotonin that are effective in OCD. Whereas in treatment of depression, we have lots of different options with antidepressants that affect different neurotransmitter systems or different receptors. And they it varies by person, but they seem to be about equivalent in efficacy. Whereas with OCD, it's largely your best chances of a response with the SSRIs or clomipramine.
Dr. Williams, what are we seeing in the way of adjunctive treatments in terms of medication, specifically and glutamate modulators, let's say?
Yeah, I mean, there's some interest in Namenda, and folks like Carolyn Rodriguez have been looking at using ketamine for OCD. That's thought to work at least partially on the glutamate receptor system, and so I think that there's definitely interest there. It's much earlier in that drug class than it is for the drugs that Dr. Davis and Dr. Goodman are laying out, these serotonin-based drugs.
And did you have any additional thoughts on any of the original questions that we were talking about, just in regards to the journey of pharmacology for OCD?
Yeah, I mean, I think I guess my view is that pharmacology and the way that we've been developing drugs, these drugs that take a long time to kind of work. I think drug development is kind of veering away from that generally in psychiatry. We're moving towards this idea of trying to do rapid acting drugs. Certainly it's a little further along on the depression front, but I think OCD is, a lot of people who do this sort of drug development work for OCD are eyeing those same drugs and trying to see if we can have a similar sort of rapid acting effect. And I think it is at the heart of it an issue that is of interest to patients because they want to get back to doing well quickly, right? And we've been involved with developing rapid-acting TMS approaches for OCD for the same reason, right? It's this idea of trying to do this faster if you can do it faster.
Absolutely. And actually, as you all know, everyone watching, if I can integrate your questions into it, if we're currently on topic, I absolutely will. Michael Schramm at 7:09 p.m. has a question, which is, what are your thoughts on venlafaxine for OCD? I'll throw that out to the group. I'm actually not familiar with that.
Sure. So I can talk briefly. So venlafaxine, the brand name is Effexor. We often use the extended release version. It's not FDA approved for OCD, but I'd say I found that it works probably equally as well as the SSRIs at high dose, because it has a significant, it acts on serotonin quite a bit as well, but it also has a norepinephrine component. But I've often used venlafaxine for OCD.
Excellent. Okay, Michael, hope that helped, and good to see you, by the way. I'm looking at some additional questions just to see if there's any other medication questions. There's an interesting question here from where we met, and actually I'll get to that in 1 second, but I want to keep rolling forward. With that, I am curious. I get this question all the time, and I know a lot of therapists talk about it, and I'm curious from a biological perspective. We always talk about, if you get on a medication, an SSRI specifically, and it works, and then you get off of it, there's not a guarantee that it will work again. Why is that, Dr. Goodman?
Why are you asking me all the hard questions, Ethan?
I've known you the longest. I don't know.
Yeah. So I don't. We don't know the answer to that either.
Okay.
But it is a well-recognized phenomenon. It first started with a number of decades ago with some studies in depression. Because we always, the goal in the past in treating depression with medications was always reach a time where you would taper them off the medication, but then found that there were certain circumstances, like if the patients had repeated episodes and they were very severe episodes, you might not be doing them a favor, getting off the medication, because you couldn't guarantee when you reinitiate the treatment that they would respond again to the same medication. And although I'm not aware that we have a lot of evidence, as much evidence in the case of OCD treatment, but I've seen that, and if I have a patient who's had a good response, their OCD's had a good response, their depression's had a good response of medication, they're tolerating it well. I generally I'm cautious about tapering and eliminating the medication. But often that's a patient choice. And some patients, and they feel that they want to take a chance and come off the medication, or at least reduce the dose. And so I'll work with them on it. But I will warn them that there is this risk you mentioned, that, and we don't understand the biology of it. Why re-challenging with the same drug doesn't work the second time.
Excellent. Thank you so much for that. I see everybody's got tons of medication questions, which is fantastic. Please load the comment thread with them. I want to touch on some of these other modalities of treatment, because I see those are questions too, and then we'll go back to the questions and try to get to as many as we can. Next, I want to talk about TMS, or transcranial magnetic stimulation. Dr. Williams, would you just mind briefly just explaining what that is?
Yeah, definitely. So transcranial magnetic stimulation is a technology that's been around since the mid-'80s, and it's kind of engineering form, right? This idea of being able to use a high-powered magnet to use something called Faraday's law to induce current in neurons. And so developed in the mid-'80s, developed as a treatment by mentors of mine in the mid-'90s, and initially looked at for depression, and then the number 2 study at NIMH was looking at this for OCD, and so I think that was published in 87, 88, something like, 97, 98, something like that. And so there's been an interest in using this technology to treat OCD for some time. The idea behind TMS that's quite useful is that it can stimulate the brain without having an effect on the tissues that lead down to the brain. So the skin, the scalp, the skull, these tissues and structures that kind of are in between the outside and your brain. The magnetic pulse goes through those, and it does so without really affecting them, because those are not very electrically conducting substances. And when you get into the brain itself, the brain is an electrochemical organ, so it's quite electrically conductive. And so the magnetic pulse then, through Faraday's law, induces a current, and then if it's sufficient enough, is able to drive neurons to fire. And the idea of therapeutic TMS is that you get into a brain region that's involved in the problem that you're trying to treat, and you push the system in a direction that's proposed to be opposite the direction that you think that the disease is pushing the system, right? So this idea of being able to stimulate over and over again with TMS is thought to change the circuit activity, and changing that circuit activity is thought to be central to the problem, central to the psychiatric presentation, if you will. And so therapeutic TMS, we do this not just once, but we do it over the course of, in the conventional form, 5 days a week for a number of weeks to get people better, and slowly over weeks, with every day, every 5 business days of getting treatment, people slowly start to get better. And at the month and a half mark, a fair amount of folks, whether it be depression or OCD, are feeling better. The great thing again about this, it's non-invasive, and the side effects are basically, the big ones are headache. There's a risk of seizure that's exceedingly rare, and that's the extent of it. A lot of people, folks with OCD that I've talked to, even some folks with depression, are worried in general about neuromodulation, whether it be TMS or DBS or whatnot, that this somehow affects your personality. And I've never seen that. That's not something with TMS that you really see. People actually will say that they feel better without feeling, strange or different in ways that they didn't want to be. And, and so that's kind of a nice feature of it.
Thank you. That's a very extensive answer. I appreciate it. And just to also define more terms, real quick, Dr. Davis, how would you define neuromodulation?
Oh, that's a good question. I'd say it's basically anything that works to modify the, I guess a way to simplify it would be transmission of signals in the brain. So the way that the brain is firing, basically. And so that can be things like magnetic stimulation. It could be electrical stimulation.
And it's using a device instead of a drug.
Right.
And as long, Dr. Goodman, as we're with you, why is the sky blue? I was just trying to ask you an easier question. I didn't want you to think that I was picking on you. But we can get back to that later. But what have we seen in terms of efficacy? I mean, Dr. Williams spoke a little bit about the efficacy and what he's seeing in patients doing TMS. What have you seen, Dr. Goodman?
Yeah, I've been impressed with some of the results, particularly, I'm not an expert like Dr. Williams is on TMS, but I was involved with one of the studies that led to deep TMS being FDA approved for OCD. And so the study results were quite compelling. And Dr. Williams would know this better than me, but are there other TMS systems that are approved by the FDA for OCD, or is it just at this point the H-coil from the BrainSway device?
Yeah, great question. Yeah, so there's that approval, and then there was kind of an equivalency application by MagVenture for a coil that looks on the surface quite different than the BrainSway coil, but if you open up both, a very similar coil arrangement. That the MagVenture one and the BrainSway one, and so that one is also approved for OCD. And I haven't heard of any other companies that have sought approval, but I assume that's coming.
Yeah, I saw that one, and then when I looked up, you're right, they did a 501(k) equivalence, which is FDA talk for how you get a device approved without doing a study.
Yeah, exactly. Yeah, they did no study. They just
So I'm a little. So if I were the patient or the prescriber, I had a choice. I'd pick at this point, given the empirical evidence, I'd pick the deep TMS aimed at midline structures in the brain.
One thing I'll just chime in that I think it's important to mention is that it's very difficult to get insurance to cover TMS for OCD right now. A few people, I think, have had luck getting their insurance to cover it, but for the most part, unfortunately, at current state, it's an out-of-pocket sort of treatment.
That makes, unfortunately, most of treatment is too. So, it's go ahead, Dr. Will.
I was just going to say, there are, somehow I get these notices. So there are insurance, like every couple of months, there's one insurance that all of a sudden is taking it. So, I mean, it is, or paying for it. It is slowly happening, but we've got studies that would be free TMS for folks. A partner site in Cornell has studies on the East Coast, lots of other places. So I think if people are interested in getting TMS for OCD, if you go to clinicaltrials.gov, there's still, I think, opportunities for folks that don't have the money out of pocket to pay and their insurance won't pay. Happy to share that info with everyone.
Thank you, Dr. Williams. Much appreciated. Let's talk about ketamine a little bit and ketamine infusions. Dr. Goodman, what is ketamine?
I'm going to pass back to Dr. Williams. He has more experience.
Exactly. Dr. Williams, what is, give us a quick breakdown on ketamine.
Yeah, ketamine is a drug that's been around for decades and decades. It's an anesthetic drug. It's used a lot in Vietnam, for instance, because it doesn't suppress the kind of cardiopulmonary system much at all. So they call it a battlefield anesthetic, right? You can give something like this for pain, and it won't have an effect on folks' cardiopulmonary scenario. Back in 2000, this was explored as a rapid-acting antidepressant. And it's one of the two molecules that are kind of mirror images of each other for what we call racemic ketamine, normal ketamine, called S-ketamine, was approved recently by the FDA for depression. Ketamine itself doesn't have an approval for depression, but is approved through kind of 60s and 70s FDA regulatory moves for anesthesia. It's used off-label for all sorts of things. So ketamine's used off-label for depression. People are using it off-label for OCD and PTSD. My kind of science contribution to ketamine was a study that I was kind of led with Alan Schatzberg and Carolyn Rodriguez a couple of years ago, and we looked at ketamine's at the opiate properties of ketamine, and that particular set of properties and the role of ketamine as an antidepressant in depressed folks, and found that we could block the antidepressant effect with an opiate blocker. That's not to say that any anti-OCD effects are driven by the opiate system, but Larry Coran did some studies, open label studies, looking at morphine for OCD and various things, and there's some view. Tom Ensel did some work with opiate blockers for OCD back in 20 or 30 years ago, and so there's some potential possible role of the opiate system in whatever anti-OCD effect ketamine has. The studies are still small ends, and they're still, the bigger ones are kind of in process, and so the big pioneer for this was Carolyn Rodriguez, who was at Columbia, did a number of studies, came to Stanford, and has NIH funding to do more. I think that I think the field's still kind of waiting on the results of those, that NIH trial, and it's my understanding is she's done with it this summer, and then we'll have some more of an answer around ketamine's role in OCD. Is it effective, in OCD in a kind of a randomized controlled trial, large randomized controlled trial, and then probably some directions forward about, if it is positive, what does that mean as far as folks with OCD getting some either ketamine or S-ketamine in the future. Still an open question.
Yeah.
Go ahead, Dr.
I think so far, I think you alluded to this, and I think it's fair to say that a body of evidence out there is quite strong, obviously, for depression, which has the FDA approval. Not as much evidence for OCD, and my own clinical experience, because I see lots of patients who are coming to me with severe treatment-resistant OCD. Many of them have tried ketamine. And I just saw a patient yesterday, and they thought it helped their depression, at least the first 2 doses, but it didn't seem to have much of an impact on their OCD. So at least where we are at present, there isn't quite as much support for ketamine's use in OCD compared to its use in treating depression.
And Dr. Goodman, any thoughts, Dr. Davis?
I would just agree with Dr. Goodman. Although I did have one patient who did feel that ketamine infusions benefited his OCD, but only when he was getting them 3 times a week. And, he was paying out of pocket 3 times a week. It wasn't really a sustainable treatment, unfortunately. He did get some relief, though.
I understand. Thank you. And great questions. Please keep them going. And again, I'm keeping track, and we'll get to your questions in the next 10 to 15 minutes. But I want to keep moving on. I think the next topic of conversation is DBS, or deep brain stimulation. This I know I can immediately turn to Dr. Goodman on, at least to start, as a pioneer in the field. Can you give us some initial insights, sir, into DBS?
So deep brain stimulation is, unlike TMS, is invasive. It's not. It's a surgical treatment performed by neurosurgeons, and it's a procedure that's used mostly around the world for treatment of severe medication-resistant movement disorders, particularly Parkinson's disease and essential tremor. So these are patients with severe movement disorders where the medications have stopped working. So the technique is, for neurosurgeons who do this, it's considered very routine surgery. And the major difference is really what area of the brain is being targeted. And worldwide, there are 2, I wouldn't say popular, but 2 favorable targets, brain areas. One is called the ventral striatum, which is the one that I've had the most experience with, and actually has a partial approval from the FDA to do it in the United States for OCD. And also, in that respect, OCD is the only disorder, at least in the United States, for which there is even a partial FDA approval for a surgical approach. And this is obviously something reserved for patients who have severe treatment-resistant. And we spent a lot of time going over records to make sure that patients have had adequate trials of multiple kinds of medications, and also ERP. And we make sure that they have that, and talk about all the alternatives available to them, including ketamine or TMS. But for some patients, it really can be life-changing. I mean, it's not a cure. None of our treatments are a cure. But for some patients who have had OCD for many years and severe, we're seeing about 65, let's say 2/3. About 2/3 of the patients are showing significant improvement, which, for somebody who's been suffering for OCD for 20 years is a remarkable achievement. So, what do I do on this? If I don't do the surgery, as a psychiatrist, I do the programming. So what happens after the patient, a couple of weeks after the patient's finished with surgery, they have a device implanted. I can communicate with that device that is stimulating this area of their brain, using a tablet with basically a Bluetooth setup. So I communicate with their device, make adjustments, and say, how you feel. And I don't ask them so much about their OCD right away. I ask them how about their mood and their anxiety, and we make adjustments over time. And usually takes a few months to optimize those settings.
That's really interesting. Dr. Davis, you obviously have a lot of experience with DBS as well. I offer you the same question in terms of what you're seeing.
Well, I don't have nearly as much experience as Dr. Goodman has, but I would agree. It's not something we consider right away. Someone really needs to have, tried all the standard treatments and not had much benefit. It's important that, like Dr. Goodman said, people going into this realize it's not going to fix or cure their OCD. And so, it's important people have realistic expectations about what DBS can do, and realize that, about a third of patients don't have what we would consider a good response. And that can be difficult to handle. Going through a neurosurgical procedure is kind of a big deal. And if you happen to be one of those people who don't respond, that can be very, very disappointing. And so that's something I talk with my patients a lot about before moving forward with surgery. That being said, the responses actually can be quite remarkable. People who have tried treatment after treatment and have really been suffering for years get some relief. And it's pretty amazing that something can have a response rate of 50 to 60% when nothing else has worked for someone.
Can I add something that may be of interest to our listeners? There's a very interesting interaction between ERP and DBS. And I just observed this today. So we're doing a study, a funded research study of trying to develop a different form of DBS. And what we built into the design of this study is after we do our adjustments for the first 6 months or so, and they're doing better. Then we give them 2 months of ERP, and we've been doing that, using virtual. So the patient I just saw today who finished those 2 months, and you look at her scores, they had been plateauing just before the ERP, and now they dropped, and she's now a responder after doing this 2 months of ERP. And I asked her, well, you had ERP before. What was different about it this time? And she said, well, before when I had it, I would do the exposure, and they would say that the anxiety would get better, and it never did. It would just get worse. It would escalate. And now, after the DBS, she does the same kinds of exposures, and she learns from each one that, over time, the anxiety will dissipate, and then she's able to go on and strip away the next ritual. So it's a very interesting interaction. And others have written about this and observed it, but to see it firsthand is really amazing. So that it actually, one way of thinking about DBS is it enhances the effects of ERP.
That's amazing.
Yeah, we require that all of our patients undergoing DBS have at least been trying to participate in ERP prior to surgery, and then have ongoing ERP after surgery, and have really found that people get better results if they're doing ERP while we're adjusting the programming.
So you're doing very similar. The difference is it looks like you're doing it right away, and we just wait a little while. We wait a few months.
I have some questions about what you just spoke about, Dr. Goodman, specifically, but we'll keep plugging along here. So because I want to there's a lot of questions. So let's quickly touch on lesioning ablative procedures, and I think that's pretty much it. Dr. Williams, do you want to touch on this a little bit? Is that also gamma knife? Is that the same thing?
Yeah, I mean, you can lesion all sorts of different ways, and I'll defer at a level to Dr. Goodman, who also has a ton of experience with this whole area. But there's the idea of deep brain stimulation came from lesions, right? So the neurosurgeons used to cut or kind of burn these small arteries that feed blood into the subthalamic nucleus, and then they knew that was a treatment for Parkinson's. You could put a deep brain stimulation lead or the same sort of thing in the thalamus for tremor. And so this idea that a lesion may work in a similar sort of way to a stimulation that kind of shuts down a brain region is an idea that has been around for a while. It's still a little controversial as to how true that actually is, but the lesions that we typically tend to use for OCD are lesions that are neuromodulation targets, right? So the anterior limb of the internal capsule is part of the neuromodulation target for deep brain stimulation. A cingulotomy is thought to be part of where the TMS is going, is the anterior cingulate, and so it's similar in that sort of way. It's permanent, unlike deep brain stimulation, which isn't actually permanent, right? You can pull the lead back out. You can, the brain is generally intact after that. There's not a lesion present once you scan that person again. Or obviously TMS, there's never going to be a lesion. With lesion surgery, there is a permanent kind of breakage of whatever gamma knife, cyber knife, the old way of doing lesions, where it's just more manual. Whichever way that happens, that circuit's kind of permanently affected, which, depending upon how one thinks about it, you could interpret that as is a bad thing. You can interpret that as a good thing, right? So if you want reversibility of what's going on, then it's a bad thing, potentially. And something like deep brain stimulation may be more in line with the way one is thinking about it. If you want something that's definitive and permanent, lesions are that, whereas a deep brain stimulator, the battery can run out. The TMS effect can eventually wear off. And so they're still done. I've been peripherally involved in a few through the years, at Stanford. I know, this happens quite a bit at Mass General, other places. But as a generality, I see a lot of folks really preferring to go down the road of deep brain stimulation just because of the reversibility aspects of it. So,
thank you, Dr. Williams. Go ahead, Dr. Goodman.
Yeah, so I agree with everything you said, Dr. Williams. So in addition to reversibility, there's the adjustability of DBS. So that's become actually my major objection to ablation now. I'm not as negative about lesion or ablation therapy as I used to be, because I've seen a lot of firsthand evidence of, and if you look at the literature, the outcomes are pretty good with some of the ablative or lesion therapies. I'm not crazy about the idea of it, and the idea of it being a permanent lesion. But what still bothers me a little bit is that I know from my own experience at programming that I need to do a lot of adjustments. And you get one chance when you do a lesion. At least with DBS, you get kind of a second chance. You hope you got the leads in the right place in the brain. That's your first priority. But even if they're a little bit off, and you don't know if they're off until you start trying it, I can actually change by programming which contacts are causing the stimulation. So it's like I'm moving the stimulation, because I can move it up and down in different places on the lead that's in the brain. But there are patients who and we've seen them here at Baylor, where we present the two options to the patients, and some patients will make the decision that they don't want to go through all the follow-up that's required with DBS, or maybe they really can't manage it. Maybe they've reached a point where it's going to be very difficult for them. And I've seen some really good outcomes. So I think there are pros and cons to both approaches.
Go ahead, Dr. Davis.
I was just going to agree with Dr. Goodman on that there are some patients who are, I think, too ill to even manage DBS, because it does require leaving your home, going to the hospital for a surgery, but then coming back for repeated visits in an office, which may be contaminated. So for some people, lesioning surgery is, it makes more sense.
And thank you. We have a lot of questions. Real quick, Dr. Davis, also I want to touch on ECT and the fact that it is not a viable treatment for OCD. Can you speak to a little bit about that?
Yeah, so we know that ECT doesn't really do much for OCD. But despite that, I can't tell you the number of people who I've met who have had ECT to try to treat their OCD. Now, if you have comorbid depression, it certainly can help the depression, and ECT is a very good treatment for refractory depression. But I'd say in general, it's important to realize that ECT doesn't really do much for the symptoms of OCD specifically.
Understood. Thank you.
Completely agree.
So I'm going to start going through. If anybody doesn't have any thoughts, I'm going to start going through these questions, and I have some of my own as well, and we'll get to them. Actually, I don't know if Where We Meet is still here at 7:12 p.m. I thought maybe they think I may be avoiding this question, but I thought it was interesting, which is, why does the OCD Foundation not think that full recovery is possible? I think that's a great question. I think the OCD Foundation is listening to the scientists at the moment, not just making that up. And I also think there's a difference between recovery and cure. And I think we have to be very clear about that. But I'll let Dr. Davis speak to this first. I think it's a great question.
So I'll say there are some instances where people do have complete remission of symptoms, but I see that more in someone who, for example, has had like a postpartum onset of OCD, where they didn't really have symptoms before they got pregnant. They have symptoms either during pregnancy or more often in the postpartum period. And then sometimes as those hormones adjust, then their OCD symptoms will remit. And there certainly are exceptions, but for the majority of people, OCD is a chronic illness. I mean, as we learn more about it, we know it is, people with OCD have, differences in their neurocircuitry in their brain compared to people without OCD. And that's not yet something we know how to fix or make different. So it's more, for most people, more about learning to live with a chronic illness. And some people have a remarkable response to medication. And as long as they stay on medication, they may not have symptoms. That's not the norm, but that does happen for some people. Some people have a remarkable response to ERP. And, with continued practice of ERP, their symptoms can remain, fairly low level. But, I'd be curious what Dr. Williams, Dr. Goodman think. But at least for most of my patients, some level of symptoms tend to persist.
Go ahead, Dr. Williams.
Yeah, I agree with that. I mean, I think it's, it's a different illness than many other things in depression, PTSD, in the sense that for a lot of folks, this starts pretty young, so it's pretty chronic. The system is kind of wired down for a long time, and so the idea that you could get a full recovery from the current ways that we're thinking about it, I think is limited. I wonder more generally if we start to to think about how to do therapies that affect, maybe intervene at a younger age. We could change disease trajectory. I think that's a possible future scenario. But I think in the current ways that we think about it, using medications, using kind of symptomatic brain stimulation, for most patients, a cure without maintenance is hard to think about how that happens. Certainly, there are handfuls of patients that get kind of functional cures from really robust, effects of drugs, but those are symptomatic improvements and go away in most circumstances when the therapy goes away. So,
could I add a couple of comments?
Of course. Absolutely.
Yeah, I liked your distinction, Ethan, about recovery and cure. And one of the reasons I don't like to use the term cure is that for some patients, it's like a jinx. It's like a dare to the OCD. Like I've had a few patients over the years who told me I'm cured. I mean, I don't have any symptoms. And then there was like a dare to the OCD, and the OCD came roaring back. So what I like to tell people is they should always be prepared that OCD is going to look for an opportunity to get back in. That it's always going to kind of be there in the background. And you need to use your tools, whether they're ERP or your medications or your device treatments, to be ready for that. And you don't want to be complacent. You don't want to think that you don't have to do any work again, because again, that's like an invitation for the OCD to come back and to try to make some inroads again. So that's why I don't use the term cure. And the truth is, from a scientific standpoint, we can't claim it either.
I agree, Dr. Goodman. I think I'm very protective about this particular topic, and especially this idea of recovery. I think when people are struggling and in the midst of treatment, whatever that looks like, the idea of chronic and just coping with this seems very morbid and depressing because of where you are. But the reality is that recovery can look amazing despite still having OCD. And it's no different than any other disease or disorder, whether it's MS or Parkinson's or anything. I have friends with MS, they do everything right. And then one day they wake up and they really struggle for a week or two, right? Their hands they can't use their hands or they can't walk. It isn't anything that they did, but it just becomes much harder to do life. And then it goes back. And I know for me in my own experience, and if you heard my story, I still have thoughts. I still compulse. I still have compulsions, but I would say 99% of the time they do not interfere with my functioning. And that's been that way for the last 10 years. And that was due to lots and lots of treatment and therapy. And I wouldn't trade where I am or who I am because of it. I wouldn't be here with you all. So, I like to say I live a very, very full life. As I understand it, my OCD will be lifelong, but its impact on me is not, because at the end of the day, it's how we respond and react to it. So at 7:14, David asked, what are your thoughts about using supplements for OCD? GABA, inositol, lemon balm, etc. Do you recommend some that you have found particularly effective? So I guess we're talking about naturally occurring. Go ahead, Dr. Davis.
I'd say some patients have a little bit of benefit with supplements. I guess probably the one I've seen the most benefit is N-acetylcysteine, or NAC. It's actually a medication they use in Tylenol overdoses. It protects the liver. It's a pretty powerful antioxidant. There's some evidence that it can help OCD, and I've had patients have some mild benefit with N-acetylcysteine. I have probably one patient who uses 5-HTP and has actually found it works pretty well for her. Otherwise, somewhat mild benefit.
5-HTP is a naturally occurring serotonin, right?
Mm-hmm. Yes, it's a supplement that can be gotten over the counter.
Yeah. Great. Thank you so much, Dr. Davis. Allison, we have a bunch. I'm going to kind of plow through these and see how far we can get. And I have some of my own as well, selfishly. Allison at 7:14 p.m. asked, what are your thoughts on the current genetic test for prescriptions? Example, Genomind or GenoCyte. I'll just throw that out to anyone. I'm not familiar with any of those.
I'm not familiar with those particular companies, but I'm not aware of any genetic test out there that would help determine which is going to be the most effective medication for somebody with OCD. So you want to make the distinction in the genetic testing of whether you're looking at efficacy, or you're looking to try to identify whether it's going to be effective, or you're going to be looking more at metabolism and side effects. I think genetic testing may be helped more in the latter, that there may be some people that either rapidly metabolize a certain drug that means that they might need a higher dose than somebody who doesn't, or it might be the other way around. Maybe they're a slow metabolizer and you don't want to give them too high a dose. Otherwise, it's going to have more side effects. So I think it's really there that in terms of maybe identifying those people that metabolize the drug differently. But I'm not aware of any evidence, strong evidence, that any of the proprietary companies of tests will help you identify which is the right drug for you.
Dr. Williams.
Yeah, that's my understanding as well. That's not really there yet. So,
understood. Thank you.
Same for depression. The American Psychiatric Association a few years ago came out with a study and a major statement and came to the same conclusions about antidepressants. I think that'll change over time, but right now it would be hard. I wouldn't rely too heavily on the genetic testing.
Yeah, and I think the most important takeaway from this question is that genetic testing will not tell you which medication is going to work.
I think that's huge, because I hear within the community all the time, yeah, my psychiatrist, I've been struggling with medications. I don't respond right or react, or a lot of side effects, but they have a genetic test down. They can tell. I think it's really important emphasize that fact for sure. So thank you, Dr. Davis. Jan at 7:14 p.m. asks, is bupropion a good medication for OCD? Dr. Davis?
Not specifically for OCD. So bupropion works on norepinephrine and dopamine, and a fair number of patients with OCD or people with OCD also have ADHD, and bupropion can help with ADHD symptoms. So if someone happens to have comorbid ADHD, it can help. It can help with depression. Doesn't tend to do a lot for OCD specifically.
Is that generic for Wellbutrin?
Yeah.
Mm-hmm.
Okay.
And it's sometimes used for treating sexual side effects associated with SSRIs.
Oh, interesting. Okay. Ellery says at 7:14 p.m. I'm in the UK and I'm prescribed. I'm going to butcher this, but pregabalin, as well as an antidepressant.
Yeah.
Okay. As for my OCD, how effective is this drug thought to be? As I seem to have had little response to it. Go ahead, Dr. Goodman.
First of all, it's not really an antidepressant. It's more of an anticonvulsant, and I'm trying to think. I reviewed some of this literature recently, and I don't remember much evidence in favor of pregabalin. But let me turn to the others on the panel.
Lyrica's approved. Pregabalin is approved for GAD in Europe, for generalized anxiety disorder in Europe. I looked at those studies. That looks pretty good for generalized anxiety. I'm not aware of any OCD approval, and I'm not clear on any dramatic. I'm not aware of any dramatic effects of gabapentin or pregabalin on OCD specifically. So
I've seen it used a lot, and maybe it'd be worth saying this. So as I guess we've already emphasized, there are only a few classes of drugs that have been demonstrated to be effective in OCD and have the seal of approval of the FDA. But despite that, if I'm dealing with somebody who has treatment-resistant OCD, I'm going to try lots of different medications and different medication combinations, because everybody's different, and we can all think of patients who responded to a medication that we didn't predict would work, but did. So as long as you're being conscientious about safety, that you're making sure that you're not using combinations that could possibly be poorly tolerated or cause some serious side effects, I always try to think of something else that might work, as long as I have a good rationale and you do it in a systematic way. And then you can, at least for nothing else, you could scratch it off the list. Say, and then we tried that. Now let's come up with another idea to try something else.
Let's talk
so
about.
Even though that we may shoot, so I guess what I'm saying is we may be shooting down all these different options, and I want people to coming away saying, "Oh, I've tried the SSRIs and clomipramine; they didn't work. There's nothing left for me." No, that's not true.
Yeah, that's a really good point.
Yeah.
Go ahead, Dr. Davis. Did you have more to add?
No, I was just going to say I'm glad you said that, Dr. Goodman, because what we're talking about what is typically works for OCD, but when you have someone with severe symptoms, we do just try a lot of different things that may or may not help. So
yeah, I've never told the patient with OCD that I can't think of something else to do.
I'm going to take a pause for a minute, because I think I'm curious, and probably a lot of people are curious. So you mentioned, treatment-resistant OCD. I'm very curious, because I have my own personal thoughts about that. So how do we define treatment-resistant OCD? What does that mean? I'll throw that out to Dr. Williams. Go ahead, Dr. Williams.
yeah, it's an interesting thing, right? So if you look at the depression literature, we have these various scales for kind of grading levels of treatment resistance in depression. Larry Coran and Stefano Palanti has this one article about kind of grading OCD treatment resistance, but it's and I'll defer to Dr. Goodman on this, but it's a less well-developed kind of description as far as the degree of treatment resistance in OCD as compared to other conditions where we have a way to define this, kind of make levels and grades of it. But it's any treatment resistant condition is failing conventional therapies, and depending upon your definition, it can be one or more than one. It can be psychotherapy. It can be medications like these serotonin-based medications.
The reason I asked that, and Dr. Davis, I want to come to you on this, and obviously feel free to weigh in, Dr. Goodman and Dr. Williams. The reason I asked that is because, and I'm just going to refer to myself and my own lived experience, and I've often asked this, which is, was born with OCD, diagnosed at 14, found proper cognitive behavioral therapy, ERP treatment at 31. Between 14 and 31, saw 10 psychologists, all talk therapy, psychodynamic therapy. I was on every SSRI that was out there at various degrees, at various dosages. I was on anafranil, which is, as you talk about, tricyclids. Couldn't tolerate it because of the side effects. And then to a point where I wasn't functioning completely. And by the time I found CBT, ERP, and helpful therapy, not only the biological factors, but just the environmental and just constantly reassuring, enabling, and all the things that, you know, I'd done for OCD and my family had done for OCD, it was pretty well cemented the way I thought, right? So I got to ERP treatment, and I was just like, this doesn't work. I've been offered all of these options. They're telling me the same. I don't have hope. I don't understand. I don't agree. And, you know, I went for 5 sessions a day, 5 days a week for 8-9 months. And then I went to residential treatment and was there for 2.5 months. And then getting incrementally better, medication switches, things like that. And then I got kicked out of residential for performing a really crazy compulsion. And for all intents and purposes, well, I thought that I had as refractory, and I'm not in any way saying I had the most severe OCD. I would never say that. But for all intents and purposes, I could argue that my OCD was treatment resistant. Or was I treatment resistant? You know, and where is that fine line? Because go ahead, Dr. Williams.
Yeah, people have kind of started to get away from this idea of the term treatment resistant because of that interpretation you just made, right? That it's somehow the person resisting treatment instead of their kind of, the way I would think about it, their brain not being responsive for whatever reason to given treatment. So I mean, it certainly seems like you know, I'm not going to diagnose you here, but it seems like you would meet kind of treatment resistant range given all the things that you haven't responded to. But you know, I think that the field sees treatment resistance as you know, is something that is not the person choosing it or having some you know, having some impact on it. It's really a biological response or non-response to given therapy, you know. So
yeah, and you want to make the distinction. And I agree. Treatment resistant may be a confusing term, but you want to talk about the illness being resistant to treatment, not the person.
And that's what I meant, and that's sort of what I was getting at. But I think my larger question is, you know, and as many people know my story, and if you don't, you can. Fran, let's put a link to my keynote just so there's context. But I was then put through sort of a tough love intervention where I was sort of kicked on the street and made to be where, you know, I had a choice. I could engage in all of the skills and tools that I had learned over the last year and choose life over OCD or not, and kind of wither away and, to be quite honestly, die, right? And after 6 days of laying in bed and not eating and not drinking and going to the bathroom in the bed, I was like, I don't want to die and I can't do this anymore. I'm going to lean into this uncertainty and engage in. I made that shift, right? I could teach ERP on therapy all day long to everybody else, couldn't do it for myself. So my brain shifted at that moment. And then obviously over the next 8 to 10 months through acceptance commitment therapy and ERP, ERP and medication, I got exponentially better. That was 11 years ago. I haven't had a relapse. Like I said, you know, OCD, I can still hear it. You know, I still have OCD and thoughts and all that stuff, but my life is gorgeous and amazing. My question is, to Wayne's point, was I just predisposed biologically and I was always able to do it? Or was there a biological reason? Or is somebody that needs maybe more in terms of treatment modalities, their as you said, their OCD literally would have never responded to ERP in that way or ACT or anything? I hope I'm making sense. I'm just trying to differentiate when is an intervening modality of treatment like this, necessary, and what is the real determining factor?
Well, so I often show your keynote to my patients because,
oh wow, thank you.
Yeah, I think your story is an excellent example of how, I mean, what it sounds like to me is basically you were faced with life and death. And when you were faced with life and death, you were able to overcome the OCD, which kind of makes sense, right? I mean, OCD feels like life and death when you're struggling with it. And it's really hard to have any perspective other than that unless you are actually faced with life and death. And some of my patients who have been more resilient are patients who have also, well, this goes both ways. Sometimes patients who have had significant trauma have a much harder time. On the other hand, I have patients who, grew up during war in a country with an active war, have severe OCD, yet function quite well because they have grown up used to managing very difficult things. So I'm rambling a little bit. I'm trying to think exactly where I'm going with this point. I guess it comes down to what are the options for that person? For you, it was an option to put you on the streets, and that worked for you. My guess is maybe having brain surgery feels more palatable to some people than being put out on the streets. And maybe having brain surgery is more palatable, more acceptable way of managing it. I think there is no right answer. And I think sometimes it can take extreme circumstances. You had extreme circumstances. I think brain surgery is an extreme circumstance. Other people may have different extreme circumstances, but don't know if that made any sense. But
Absolutely, Dr. Davis. Thank you. Dr. Goodman, and please, Dr. Williams, weigh in as well if you have thoughts. I want to so I know just because I speak so much, as you can tell, I'm super passionate about our community and helping as many people as we can. We're all in this together. OCD in the heat of it, as you all know, I'm speaking to the choir, can be so painful and so tumultuous, and ERP can seem so daunting, right? That anything to latch onto that seems like easier than what I have to face doing is just like, let me grab that. And I know if I were listening, like, oh my God, this TMS could take this away. I want to do this. I want to what. And you touched on this, Dr. Goodman, in terms of approach. We ask questions. We at least see that you've been on multiple medications before we do DBS and the ERP. But what would you say to individuals that are struggling and suffering, that may be going through treatment right now and like looking for something to latch onto, and really hearing this and going, oh my God, that's it. That's my answer. That is my super quick path. Yeah.
Yeah. I mean, what you're talking about is it's really hard to generalize. I mean, I'm very cautious about making blanket statements about what's the best treatment or combination. Everybody's going to be different, and it really requires. The first thing is you have to make sure that you're being seen by a clinician who's experienced with OCD, and so that have somebody go through your record, your type of symptoms, and look through very systematically what treatments have been tried and whether they've been adequate. Going back to the discussion earlier about treatment resistance, that's also linked to the ideas when you're going through treatments, you have to make sure that the treatments were adequate. Whether they were medications, and how do you define adequate? It's by what dose they achieved, how long they were on it. ERP is the same thing. ERP, also you have to look at the dose. And I've had patients say ERP didn't work for me, but it turns out they went to the wrong therapist. And who really wasn't schooled enough in ERP, or maybe they didn't have enough sessions, so that the dose wasn't high enough. So I think that I hope that nobody comes away from listening in on this saying, oh, well, this is the treatment for me. There is no one answer, and there are lots of options.
And I think that's beautifully said, Dr. Goodman. I think that, and the idea that there's lots of options should give a lot of hope, to that fact that there are lots of options. And OCD, we know, is one of the most treatable mental illnesses of the group. Dr. Williams, do you have any thoughts?
Yeah, I mean, I agree. with everything that Dr. Goodman and Dr. Davis said about this. I mean, yeah, we want folks to kind of come out of this with hope, and I think that's the biggest piece, and that there's a lot of interest in treating OCD and developing new therapies and kind of going forward with neuroscience-based treatments is going to be an important step for the future. So,
to that point, Dr. Williams, are some of the modalities that we talked about, do you think at some point might be a first-line treatment for OCD down the road?
Yeah, it's a great question. I mean, the TMS, move for OCD, it's pretty safe from the BrainsWay trials. It looks pretty safe. It's pretty safe in general. Historically, the reason why we haven't done TMS trials in treatment-naive individuals is because it's incredibly expensive to do TMS relative to off-label, label drugs in the sense of being a drug that's off patent rather. Those drugs are relatively cheap. TMS is in the kind of $20,000 to $30,000 range. Also, the placebo rate for folks that are treatment naive is higher. So constructing trials that are for folks that haven't done any other treatments, it's a harder bar because there needs to be probably larger samples to be able to pull that off. But if one could identify a subpopulation of OCD patients through some sort of biological measure that we're destined to be much more treatment resistant than, and we do this in epilepsy and other kind of brain conditions, we can kind of predict who's going to respond and who's not going to respond. So if we had a tool in the future to be able to do that, I could see a subpopulation going directly to TMS, even potentially going to even more invasive things if you could define that ahead of time, because you'd cut a bunch of time out. But you really need to know that. You'd kind of need to know that you could define that. The other kind of technological trajectory that's happening is this idea that one could use even less complex devices at home, right? So, people have looked at TDCS, which is pretty weak for OCD in the trials that have been done, but other devices like transcranial alternating current stim, and people are developing take-home TMS devices. And so, you could see something like that being a device that could be developed for a less treatment-resistant OCD patient. And I think that there's certainly interest in industry to do that. But it's going to take some time and some more science to really figure that out. And we're just at the point now where we've got an OCD TMS approval. We've got one pivotal trial. We need more data and more understanding about how this works, and potentially more TMS targets and more, even potentially more DBS targets, right? So there's a lot to do between now and then, I think.
Thank you, Dr. Williams. Dr. Davis, I have a couple questions coming at you, so hang tight. Dr. Goodman, is there, I love talking to you about this because you're literally on the forefront of this. Is there a situation where DBS might be a frontline future and a frontline treatment? And also, I'm curious as to increasing efficacy as you continue to, investigate and research. How effective do you think it can eventually go? Do you think the future is deep for DBS?
I would never envision deep brain stimulation being first-line treatment.
Okay.
No. First-line treatments are going to be ERP and SSRIs, and hopefully some new medication or TMS. Surgical treatment like deep brain stimulation, although the risk profile is acceptable, there is the potential for serious risks in a small proportion of patients. So you would never, and it's costly. I don't have to go into all the reasons, but no, the simple answer is I would never see it as a first-line treatment. My interest in part in it is, and this is something Dr. Williams mentioned, is because it allows us an opportunity to learn more about the neurocircuitry of OCD. So the study I'm involved with now, we're not only stimulating the areas of the brain that we think may make reduce symptoms of OCD, we're also recording from the brain. And in so doing, may learn more about the neurocircuitry. And the goal would be to learn enough that we can maybe identify even better targets for DBS or better targets for neuromodulation that don't involve surgery. So that would be the goal, is to go through this period where we're doing more invasive work, because it allows us to get information directly from the brain and then develop a new treatment that's less invasive.
That's amazing, because we don't know exactly. We know the idea of the area, right, Dr. Goodman or Dr. any of you. We know kind of the area of where OCD exists, but we don't know exactly how specific do we know where OCD comes from?
Well, you know, so we know about circuits, and but they're still hypotheses. They're not completely proven. And when you talk about a circuit, that gives you the option of intervening at different nodes or points in that circuit. And you can make the case that our various treatments, whether they're ERP or medications or devices, act on different points in different ways on that circuit. But even in the case of DBS, I said that there are two areas of the brain that they're often implanted with the electrodes, but maybe there's a better place. We just don't know that yet.
Did I go?
No, you're here.
You stood there, Ethan.
Oh, well, maybe you're frozen.
Oh, you are frozen, Ethan.
Oh, okay. Am I back?
Yes.
Okay, apologies. And thank you so much for let's jump back to questions. And thank you, Dr. Goodman. I really appreciate that response. 7:15 p.m. This is a great question. So Tara asks, and I'm going to throw this at Dr. Davis. Do you find if a patient is on medication for a number of years, it will become less effective for OCD symptoms, or it stays just as effective for long-term, 10, 20 years, et cetera?
Depends on the patient. I'd say a lot of patients, it stays just as effective long-term. Other patients, it does seem like, you know, it's either the medication stops working or the symptoms gets worse. I think often what it is that life is hard and things happen and symptoms get worse, and then it seems like the medication doesn't work as well. But yeah, sometimes it does seem like it just doesn't work like it used to for people. But that's not the norm.
Understood. Dr. Williams or Goodman, do you have any other experience?
Yeah, I mean, that happens. It's, you know, I think everybody said this earlier, that this is a phenomenon that happens. We don't know why it happens. Certainly there's an equilibrium that the brain is, you know, constantly trying to achieve in these scenarios, and sometimes that shifts, right? And we don't have good measurement tools to measure effects of medications in the brain, so we can't measure changes in those effects, unfortunately.
Thank you, Dr. Williams. Dr. Davis, on the continued topic of medication, how effective or in conjunction with SSRIs are antipsychotics or mood stabilizers?
So antipsychotics, we know, tend to be particularly effective if someone also has a tic disorder or Tourette's. In people who don't have a tic disorder, it's hit or miss. And there's actually some evidence, and I can say I've seen this clinically too, where at least some of the newer antipsychotics can make OCD worse. That's not common, but it can happen. In people who don't have tics, I'd say antipsychotics, especially the newer ones, often help with the mood component. And so we do use them in conjunction fairly often. Because, as you know, a lot of people with OCD also have significant depression, and the antipsychotics can help with that. But really, you know, in people with tic disorder, I, you know, almost certainly want to make sure I've tried an antipsychotic if they have significant residual symptoms, and it will help not only the tics but also the OCD often. And then mood stabilizers, you know, that's hit or miss as well. You know, if someone also has bipolar disorder and they have OCD, there's a subset of patients who, if you treat the bipolar itself with, for example, lithium, the OCD will actually get better. Again, that's not typical. That's just a subset of patients. Often, if someone has both, it's a balancing act of, you know, treating the OCD with a medication that acts on serotonin, which is usually an antidepressant, but we know that can make bipolar disorder worse. And so it's balancing that with the mood stabilizer for the bipolar. So that's one situation. And then there's a question of using mood stabilizers for OCD itself. There's small bits of evidence that things like lamotrigine, which also acts on glutamate, can help certain people with OCD. Interestingly, I actually gave a patient OCD and tics once with lamotrigine. She was someone who did not have OCD at baseline. So I think that just speaks to like the complexity of our neurocircuitry and how in someone who doesn't have OCD, I actually made things worse by giving her lamotrigine. But I have other patients who take lamotrigine and they get benefit for their OCD. There's some evidence that topiramate, which is also a mood stabilizer, often used for migraines as well. Some people benefit from topiramate. A lot of people can't tolerate topiramate, but I had one patient who that was the only thing that worked for her was high doses of topiramate. So,
thank you, Dr. Davis. We got about 10 minutes left, and obviously lots and lots of questions about medications. I could keep going on, but I also want to speak to, because I know so many people, I also want to speak to the stigma of medication, and I'm interested from all of you. What is a good frame of mind an individual with OCD or related disorders should go into meeting with a psychiatrist or an expert, an MD, and because it is trial and error to a certain extent. You don't know off the bat, like, okay, I'm going to put you on this milligram of this medication and it's going to work. They're not as targeted yet. So how do you suggest individuals with OCD work with their therapists? They're psychiatrists in a meaningful way, where the word I always felt like a lab rat. I did, and I know so many others do as well. Well, how would you suggest we engage with our psychiatrists in a helpful way that we can work together and not kind of reduce that idea of stigma?
Well, I think one approach is to look at OCD as we described it earlier, in many cases as a chronic illness. And again, it doesn't mean that it's going to hamper your life. But if you were diagnosed with diabetes or hypertension, the treatment might involve changes in diet, exercise, and medications. And so I would see it as no different in the case of OCD, which is clearly a brain-based disorder. And I have no problem confessing that I can't claim from the get-go which medication is going to be best for a patient. And I'm very clear about that. But that we're going to try something, we're going to do it in a very systematic way. And if it doesn't work out, we're going to try something different. And we're going to make sure that the person is tolerating the medication as best as possible, and make sure that they let me know if they're having any problems.
I just think that's so important to hear from psychiatrists and doctors like you, Dr. Goodman, and everyone, because I think it's often forgotten, at least on, OCD can be so black and white, right? So it's so easy for us to frame it as, oh, well, you don't know what I'm going through. You're just experimenting on me. And that's not the case oftentimes. Dr. Davis, what are your thoughts?
Well, I would agree with that. And I think people with OCD are often more sensitive to side effects. And the way I kind of conceptualize that is, just kind of a hyperactive nervous system. And so people often have more side effects. And I would kind of expect that going in, and rather than kind of running away if you have side effects, really engage in a conversation with your psychiatrist about, this isn't tolerable, what can we do about it? I will sometimes start people on a liquid formulation at 1 milligram and go up as slow as necessary. I tell people this right up front. We may try 6, 10 things before we find something that works. I don't see that as a failure. I don't see that as something wrong with you. I see that as a normal part of the process. And I will keep trying things until we find something that helps you. And so I encourage people not to get discouraged by that and try to normalize that part of the process.
Thank you, Dr. Davis. Dr. Williams.
Yeah, I take a similar approach to what Dr. Davis is saying. I mean, I try to do very low doses and try to really set people's expectations a little bit about how this is going to go. So this idea that we don't have tests that will give us the right answer for for which drug, and a lot of folks with OCD do have, more side effects from some of these drugs, experience more side effects than people taking it for other reasons. And so to go kind of low on the dosage and slow and set set a clinical environment in which the patient feels comfortable to kind of be fully transparent about how they're feeling, and whether it be with side effects or just the symptoms themselves, and that, I think that in the long term is the right way to kind of set it up and set the clinical expectations. So.
Thank you, Dr. Williams. Great question from Jessica at 8:23. I know Fran's having some internet troubles. Oh, no, he's back. Sorry. At 7:23 from Jessica, how long did you try a med before you decide to change? If there are no improvements in symptoms, what is the barometer?
I think we mentioned the ballpark earlier. It's somewhere between 8 and 12 weeks. In that range.
If you're tolerating it.
2 or 3, yeah, if tolerated, right. So assume somebody's tolerating it, and you've got them up to a dose that's therapeutic and maybe a little bit beyond what you normally do in depression, and 10 weeks, 12 weeks, something in that ballpark has expired. It's time to either add something to it, and what we call adjunctive medication, or to try something different.
Thank you, Dr. Goodman. I'm going to keep plowing through. Dr. Nolan, Zadie asks at 7:25 p.m., could TMS, it says, could TMS be good for a 14-year-old boy that has been struggling for 2 years with therapy, medications, and been in residential for 6 months?
Yeah, so kind of the official statement is TMS is not approved for folks that aren't adults, right? And it hasn't been studied. Do people do it? I've heard that. We don't. And there probably needs to be a study for that specific age group. But it's certainly something. 4 years from now, when this individual is 18 or older, it would be something to definitely start to think about as a possible option. But that's just a reflection of all the work we need to do, right? We need to do this sort of work now, try to, whether it be Brainsway or somebody else, trying to expand the OCD label down to younger teenage folks. It's worth thinking about.
Absolutely. Thank you, Dr. Williams. And I know we always have so many families and kids, and I know there's always so much hesitation to start children on medication for OCD from the parent side. Dr. Davis, what would you say to that? I know Dr. Goodman obviously talked about, it's a disorder just like anything else. Would you say the same thing in children?
Yes, absolutely. I mean, I think if you have a chance to intervene in childhood, you could be potentially saving that child a lot of grief later on if they respond well. And, the brain is still developing, and if you can help the brain, develop in a more, or let's say a less painful way, that child might have a more pleasant life growing up than they would otherwise.
Thank you. Go ahead, Dr. Goodman.
Yeah, it's. How do you know I want? You seem to know when I want to speak. I don't know how I'm giving it away.
No, you have to tell. We can't play poker. I won't share with anybody else in case you ever.
Yeah, I'm definfinely not playing poker with you. You'll know my hand every time.
Yeah.
Yeah. No, so with kids, I mean, there's no question that ERP is first line with kids. I mean, when you start contemplating use of medications in kids, if they're not responding to ERP or there's significant depression, they can't adhere to the ERP, and there are fewer options, and you have to be more careful with using antidepressants in kids. And I'm not trained as a child adolescent psychiatrist, so I really leave that up to my colleagues who have that specialization.
Thank you. Go ahead, Dr. Williams. Or are you just Blair Witching it?
No, just shifting the computer. Yeah, I agree with everything that was just said.
Perfect. We only have a couple minutes. I do want to read Williams' comment. He writes, you don't need to post this, Fran. Brushing up on current research and ran upon this article, Harmonizing the Neurobiology and Treatment of Obsessive Compulsive Disorder. Guess who the lead author is? Dr. W. Goodman. I'm telling you, the man is a beast. Thanks for the great information, all. So
It took me weeks to come up with that title.
Harmonizing it has a nice ring to it. It really does. So with that, I very much want to thank Dr. Williams, Dr. Goodman, and Dr. Davis for taking the time and joining us. So thank you all so much for being here and answering questions. I know your schedules are very, very busy, and we're very grateful for you to be here. On that note, I know there were a lot of questions that were asked. I apologize that we didn't get to all of them. If you have questions, please don't hesitate to email your questions that you asked here to info@iocdf.org. Fran will put that up now, and we will be happy to forward your questions along to Dr. Williams, Goodman, or Davis. Just ask us just let us know who your question is for, and I'm sure we can get a response back and get that to you. If y'all wouldn't mind, that would be great. Also, I want to thank the IOCDF and, of course, Fran behind the scenes for doing his magic. Just some upcoming content. Tuesday, the 6th at 7 p.m. Eastern is an episode of Just Ethan with Just Ethan. So you'll want to tune in then. And then on Wednesday, the 9th at 7 p.m., the next day, we'll have another town hall on our anxiety and athlete series. This is superstition versus compulsion, with Tom Smalley and guest Callie Warner. So those will be 2 live streams for next week. As always, you can visit our programming, which is iocdf.org/peace of mind for all of the virtual programming going on. We've got loads and loads of content in addition to multiple live virtual conferences happening over the summer. We just had our faith and mental health conference, which was a wonderfully huge success. Dr. Goodman, I have to ask you, how do you feel seeing all of this from what you started? It's got to make you feel amazing.
It's the thing I'm most proud of.
Well,
absolutely, yeah.
Well, thank you, because we're all grateful to be doing our small part. If you haven't already, you want to be notified about all the programming the IOCDF is having over the next month, definitely be sure to subscribe and follow on Facebook and on YouTube and Facebook, and also on Twitch. And with all of that, thanks, Dr. Goodman, Dr. Williams, and Dr. Davis again for joining me.
Thank you, Ethan.
No, my pleasure. Thank you, Dr. Davis. Thank you. It was a pleasure meeting you all. As always, again, you can email the foundation info@iocdf.org. Have a great Thursday evening. Stay safe, stay vigilant, feel the feels. Don't let OCD off the hook. And we'll see you soon. Thanks.